Hi everyone, hope you're all doing great. In this video, we are going to discuss about prenatal screening. So it is prenatal screening. So this is basically a screening done in the fetus in earlier stages of pregnancy to rule out any anomalies or other chromosomal anomalies. Okay. So with this you can help the baby without born with a specific syndrome or you can go for any intrauterine treatment for the baby if needed, or you can even help the couples for a different mode of reproductive technique to avoid these complications. Okay, and anomalies we already know. Trisomy 21 is the most common anomaloid, followed by trisomy 18 and then it's trisomy 13. Okay. Now, what are the risk factors of aneuploidy screening? Okay. 1. The maternal age is more than 35 years. Then there is a consanguineous marriage between the couples. There is a history of infertility, past history of chromosomal abnormalities in their kids, and even if the couples are having any translocations, say balanced translocation or a reciprocal translocation, or in the USG if you are finding any markers of aneuploidy. Understood? Now, even then these are the risk factors. Our guidelines say that aneuploidy screening should be offered to every mother. Okay, this is important. Now, what are the methods of aneuploidy screening? We have number 1 is Analyte-based screening, and then it is cell-free DNA based screening, which is otherwise known as non-invasive prenatal testing. We will see what is Analyte-based aneuploidy screening. Okay. So, Analyte-based means we will be checking a particular markers that are going to cause aneuploidy. Okay. For example, in the first trimester, we can do a dual testing. From the name itself, you can understand two markers are used. Number 1 is β-hCG and number 2 is PAPP-A, which is pregnancy associated plasma protein E. Okay. Now, always remember, okay, that in Down syndrome, hCG is always high. Okay, hCG is always high in Down syndrome. So, if we take this and see the results of 3 trisomies. So, β-hCG value will be increased and PAPP-A value will be reduced in trisomy 21, and in trisomy 18 and 13, both the markers are going to get reduced. Understand? So, this is dual testing. Next, if we want to do the test in the second trimester, we can have 2 options. One is triple test, that is also known as Barth's test or Catering test, but this is an outdated test. We are not doing it anymore. We will be using the markers like free β-hCG, then unconjugated estriol. In this, we will be using the markers like free β-hCG, alpha fetoprotein and unconjugated estriol. Okay. But to this, another marker was added and that test became to be known as quadruple testing, and this is the most commonly test done nowadays, and it is usually done between the gestational age 16 to 18 weeks. Okay. So, if you ask me what are the markers, the same markers used in triple testing, that is free β-hCG, alpha fetoprotein, unconjugated estriol and inhibin-A. Okay. And if we see the results of the 3 trisomies, namely 21, 18 and 13, okay. Remember, I already told you H is going to be high in Down syndrome. So, how you will be interpreting the results? Yes, in free β-hCG will be high in 21 and alpha fetoprotein, unconjugated estriol and inhibin-A are going to fall. Whereas in trisomies 18 and 13, the first 3 markers are going to fall, whereas inhibin-A levels are going to be unchanged. Understood? Okay. So, this is quadruple testing. And with the quadruple testing, you will be able to identify 80% cases of the Down syndrome, and the values of each marker is given in MOM, that is multiples of median. Okay. Now, in multiples of median, concentration of each serum marker is going to be compared with the range of serum marker in normal pregnancy. Okay. Now, we will see some of the factors which can affect these values. They may include maternal age, if she is a diabetic, if there is a multiple pregnancy, if there is smoking and any artificial reproductive techniques are used for conception. Okay. We will see some USG findings that can be seen with aneuploidies. So, in the first trimester, we will be doing NT scan, that is nuchal translucency scan, between 11 to 13 weeks of gestational age, and when the CRL is between 45 to 84 mm. Okay. So, what is this nuchal translucency? Nuchal translucency is a space that is seen between the skin of the back of neck and the tissues covering the spine. Okay. The normal NT thickness is less than 3 millimeter. So, any time if you have an NT value more than or equal to 3 millimeter, then you have to do further testing. Understood? Now, remember, this is not a diagnostic method again, and 70% cases diagnosed with increased NT will have Down syndrome. Okay. So, this is how you measure NT. Okay. So, this is the space that is seen in the back of the neck. Okay. So, while measuring NT, remember that it is taken in a mid-sagittal plane and the head, neck and even the thorax of the fetus should be visible in the same plane. Okay. And the head should not be moving. Okay. So, head should be fixed. Then only you have to measure the NT. Okay. So, this is a translucent space seen at the nape of the neck. Okay. And in the second trimester, you will be able to see a list of markers which are known as soft markers of aneuploidy, because this can be seen in normal fetus also. About 11 to 17% of the normal fetuses, and these are usually transient features that it may go off during the later gestational period, and there is an increased risk of aneuploidies. So, further testing may be needed. Okay. So, the soft markers include number 1, increased nuchal thickness. Okay. So, remember, this is not nuchal translucency, this is nuchal thickness. Okay. And it will be more than 6 millimeter. And there can be absent nasal bone or a choroid plexus cyst or echogenic bowel or echogenic intracardiac foci. There can be shorter long bones like short femur or short humerus. There can be sandal gap or Sivian crease, and there can be pilectasis, okay, of the renal pelvis. Okay, so these are the 10 soft markers, and among these 10 soft markers, even if you see 2, then there is a strongly associated with aneuploidies. Okay, so if we see this, you are able to see there is an intracardiac focus in the bowel. Okay, the same way this is the heart. In this also you are able to see an echogenic focus. Okay, so this is a choroid plexus cyst. Okay, and here there is pilectasis, which is basically dilatation of the renal pelvis. This is a normal renal pelvis, and here if you see there is a dilatation of the renal pelvis, which is known as pilectasis. We will see what is nuchal thickness. Okay, it is different from nuchal translucency, and it is measured from the outer margin of the occipital bone to the outer margin of the skin. Okay, and at this point I want you to give an idea about cystic hygroma also, because this is also going to be a fluid connection that is happening in the neck. Okay, so basically what is cystic hygroma means? It is collection of lymph in the lymphatic channels, especially in the neck. So it is the jugular lymphatic channels due to obstruction. Okay, and this can be seen in both first trimester or the second trimester. If it occurs in the first trimester, then the most possible causes trisomy 21, which is Down syndrome, whereas if it occurs in second trimester, it is mostly monosomy X, which is Turner syndrome. And remember, when compared to NT, okay, this cystic hygroma feature, if it is seen, this carries more risk. Okay, and if it is seen, diagnostic methods should be done immediately. Okay, so we'll see some Doppler markings also. So remember, this is not generally done in first trimester. Okay, so some findings may include reversed end-diastolic flow, then absence of flow in the ductus venosus, then tricuspid regurgitation. Okay. Instead of doing all these tests separately, like the markers separately and the ultrasound separately, they can be combined together and can be done. That is known as combined screening. So, where you will be combining the first trimester screening methods, namely the dual testing and USG for NT together. Okay. So, what we do in dual testing, we check it is β-hCG and PAPP-A. Okay. To have a better orientation, we will discuss only about Down syndrome. So, what is going to happen to the values of β-hCG and PAPP-A? β-hCG is going to be high, okay, and PAPP-A is going to be reduced. Okay, and NT, the thickness is going to be more than or equal to 3 millimeters. Okay. Now we will see some other conditions in which these findings can be found. Okay. In the dual testing reports like β-hCG is increased and PAPP-A is reduced can also be found in fetal growth restriction or preeclampsia or uteroplacental insufficiency. Okay. And USG for increased NT can be found in conditions like other trisomies, then any cardiac anomaly, diaphragmatic defects, renal anomalies, when there is hydrocephalus or hypoplasia of lung, or when there is body stalk disruption leading to abdominal wall defects. Okay. There is also a method called combined serum screening where all the markers will be used together. For example, β-hCG, alpha-fetoprotein, unconjugated estriol, inhibin-A and PAPP-A. So, remembering Down syndrome is very easy now, right? So, what is going to happen? Only hCG is going to increase and all the others is going to reduce. Okay. Also, we have some protocols for this kind of screening. One can be integrated protocol and the other one is a sequential protocol. Okay. So, what we are going in this integrated protocol means we are going to do the first trimester screening, but the reports are not informed to the patient. Okay. So, basically reports are withheld, okay, until we do the second trimester screening. Okay. But in sequential screening, we follow a stepwise screening. Okay. So, first trimester screening, you inform the patient, discuss the problems. Okay. Then if needed, we do a second trimester screening or other modes of screening. Okay. For example, if you do a first trimester screening and you are getting it to be a high risk case and a low risk case. If a high risk case, immediately you go for a diagnostic method like chorionic villus sampling or amniocentesis. Okay. And if it is a low risk, you can offer quadruple screening in the next trimester. Okay. Suppose if the woman is having a previous history of aneuploidy, then don't waste time by doing the screening again. Okay. We will be directly going for the diagnostic methods. Okay. So, for Down syndrome screening, in India, most of the laboratories are giving a cutoff in the range of 1:250. Okay. So, if suppose there is a cutoff like 1:150, that means for every 150 persons, the risk is 1. And there is a cutoff I am getting for another patient 1:5500. Okay. In which the risk is more? Yes, the risk is more in this case. Okay. So, here I can offer them CVS or amniocentesis, okay, or we can even go for non-invasive prenatal testing. Okay, and if this is so, either you can offer them NIPT alone, and even more the risk is lower. We'll even discuss about non-invasive prenatal testing. Okay, so this is mostly done after 9 to 10 weeks of gestational age. What is the concept in this testing is, we are going to take the maternal venous blood and going to check for the cell-free fetal DNA that has come into the maternal blood, because this cell-free fetal DNA can pass through the placenta and can reach the maternal blood. Okay, so we are basically going to test this cell-free fetal DNA, and remember, this is done for screening of trisomies, that is 21, 18 and 13, and also for monosomy X. And this is one of the most sensitive and specific method, having mostly positive predictive value. But remember, this is also not a diagnostic test. Okay, it is only a screening test, and whatever we are not going to offer it as it is more expensive to the patients. Okay, so not offer. Okay, suppose if there is positivity in this test, we can offer the patient amniocentesis and genetic counseling. Okay, so this is all about prenatal screening. Until we meet in the next video, happy learning, keep going and take care.